Welcome to Night Shift Scientist, a collection of real medical cases pulled from the literature, exploring strange and fascinating presentations, told in a calm and thoughtful way to help you fall asleep. These stories are for the curious mind. They're told with just enough medical detail to hold your attention, and enough space between the words to let your thoughts settle. So let the rhythm of the story wash over you as you unwind, relax, and drift off to sleep. My name is Stephen, and I'm a public health researcher based in Western Australia. Tonight's episode is all about toxicology, unusual poisonings, rare antidotes, and the complex dance between timing and survival. Every case you'll hear is real and drawn directly from published medical literature. You can find links to the full articles in the description below. If there's a topic or a case you'd like to hear in a future video, feel free to leave a comment. I'd love to hear your ideas. Before we begin, please note that while this episode focuses on the medical aspects, it does include references to suicide. If you or someone you know is struggling, support services are listed in the description as well. Now, settle in, close your eyes, pull up a blanket, maybe turn on a fan. Here we go. Introducing our first case, a 26-year-old woman living in a busy urban center. She arrives at the emergency department 3 hours after ingesting 2 heaped teaspoons of powdered caffeine, which delivers about 20 grams or roughly 231 milligrams per kilogram of her body weight. She feels her heart pounding, her palms slick with sweat, and an unsettling tightness in her chest. She struggles to catch her breath, a sensation known as dyspnoea, or difficulty breathing, that drives her anxiety even higher. Her past medical history includes depression, a mood disorder characterized by persistent low mood and loss of interest, and panic disorder, which causes sudden episodes of intense fear. She takes fluoxetine, an antidepressant that boosts mood by increasing brain serotonin, and propranolol, a beta blocker that slows the heart rate by blocking stress hormones such as adrenaline. She also uses a combined contraceptive pill, which can slow caffeine metabolism in the liver. She describes that she does not drink alcohol or smoke or use illicit drugs. On examination, her vitals are elevated, but not abnormal. She is tachycardic, with a heart rate of 109, her blood pressure is 116/67, and per oxygen saturation is 99% on room air. Her Glasgow Coma Scale is 14 out of 15, which dips later as she progressively becomes agitated and breathless. Further investigation reveals polymorphic ventricular tachycardia, an irregular and potentially dangerous heart rhythm arising from the ventricular chambers. Considering these findings alongside her presentation, several differential diagnoses emerge. One possibility is acute panic attack, a sudden surge of overwhelming fear, but her EKG changes and metabolic disturbances make this unlikely. Another is pheochromocytoma, a rare adrenal gland tumor that releases stress hormones, yet she lacks classic episodes of hypertension spikes. A stimulant overdose from other sources might explain her tremors, but her clear history of powdered caffeine ingestion points definitively to caffeine toxicity. Further testing confirms the diagnosis. An arterial blood gas shows metabolic acidosis when the blood becomes too acidic, alongside respiratory alkalosis, reflecting her rapid breathing blowing off carbon dioxide. Her blood potassium level falls to 2.4 millimoles per liter, a state called hypokalemia, and the first caffeine level measures 147.1 milligrams per liter 7 hours after ingestion. These lab values plot neatly along a first-order elimination curve, indicating that her body is clearing caffeine at roughly a 6-hour half-life. A brief sidebar on how caffeine works. Caffeine acts like a key that fits into adenosine receptors throughout the body, preventing adenosine, a natural calming chemical, from binding. This blockade leads to increased alertness and, at toxic levels, heart rhythm disturbances as electrical signals race through the heart. Caffeine also inhibits phosphodiesterase enzymes, which normally break down signaling molecules, and causes the release of calcium inside cells, like turning up the volume on every muscle fiber. In the intensive care unit, she receives continuous heart monitoring every few minutes, intravenous fluid and electrolyte replacement, and invasive ventilation to control her breathing. A central line is placed for haemodialysis, a process where her blood is filtered through a machine to remove excess caffeine. She remains sedated with midazolam, a fast-acting sedative, and fentanyl, a potent pain and anxiety reliever, and is paralyzed with rocuronium to synchronize her breathing with the ventilator. Her treatment unfolds gently but decisively. 50 grams of activated charcoal is given to bind any remaining caffeine in her gut. Intravenous lipid emulsion, known as Intralipid, acts like an oil slick that sequesters fat-soluble caffeine molecules. Haemodialysis runs continuously, pulling caffeine directly from her bloodstream. When her blood becomes dangerously acidic and potassium levels swing high, 2 boluses of sodium bicarbonate correct her acid-base balance, and 20 millimoles of magnesium stabilize her heart's electrical pathways. A low dose of norepinephrine supports her blood pressure by tightening blood vessels. By the next morning, she remains intubated and on dialysis, but her heart rhythm has steadied. On day 2, sedation and dialysis are stopped, and she breathes on her own once more. The breathing tube removed without difficulty. Over the following week, she has one brief spell of rapid breathing and low oxygen thought to be aspiration pneumonia, but it resolves with gentle care. She leaves the ICU after 8 days with intact kidney function and no further arrhythmias. Coffee, the world's most popular stimulant, has been enjoyed for centuries for its comforting warmth and alerting qualities. Yet this case reminds us that even familiar substances can become dangerous in large doses. This story offers several gentle lessons. Our physiology depends on a delicate balance of chemicals, and when a single molecule like caffeine floods the system, it can trigger a cascade of effects from heart rhythms to acid-base disturbances. Intensive care often means weaving together multiple therapies, sedation, dialysis, electrolyte correction, to support every system at once. In cases of severe caffeine toxicity, treatments such as intralipid and haemodialysis can be life-saving, and magnesium may restore a perilous heart rhythm. Finally, this patient's recovery underscores the resilience of the human body when given attentive, coordinated care. Introducing our second case, a 67-year-old man living alone with a long history of alcohol dependence and prior hospitalizations for substance overdose. Tonight, he is brought to the emergency department by paramedics. He was found unresponsive in his home. When he arrives, he is groggy and clearly intoxicated, but within minutes, his condition worsens. His eyes drift closed and his breathing slows. Soon, he slips into a deep coma. His Glasgow coma scale is 3, the lowest possible. This man has a long and difficult relationship with substances. He has overdosed before on both alcohol and benzodiazepines, which are sedative medications often prescribed for anxiety and insomnia. He has no known recent travel or changes in diet, but his alcohol dependence is long-standing and severe. On arrival, his vital signs are mixed. His blood pressure is normal at 133/65. His pulse is elevated at 100 beats per minute, and his respiratory rate is 20 breaths per minute. Because he is comatose, the team performs an emergency intubation to secure his airway, and they begin giving him fluids through an intravenous line. A CT scan of his brain shows no signs of bleeding or stroke. His blood tests raise concern. Sodium levels are high at 158 milliequivalents per liter, and his blood is highly acidic, a condition known as metabolic acidosis. The anion gap, which helps measure the buildup of unmeasured acids in the body, is very high at 32. Lactic acid is nearly 9 milliequivalents per liter, which suggests tissue is being starved of oxygen. But most notably, his osmolar gap, a number used to detect unusual substances in the blood, is extremely high at 271 millimoles. The normal range is below 10 millimeters. A toxicology screen shows ethanol in his system, about 53 milligrams per deciliter, but no sign of other common alcohols such as methanol or isopropanol. Based on these findings, the clinical team strongly suspects toxic alcohol ingestion, particularly ethylene glycol, which is found in antifreeze. Ethylene glycol is a sweet-tasting liquid found in many household products, including windscreen washer fluid and some paints. Once swallowed, the body begins to metabolize it, using an enzyme called alcohol dehydrogenase, the same enzyme used to break down ethanol. But in the case of ethylene glycol, this process creates harmful compounds, such as glycolic acid and oxalic acid, which damage the kidneys, brain, lungs, and heart. Recognizing the danger, the team immediately gives him fomepizole. This is a medication that blocks alcohol dehydrogenase, preventing the body from converting ethylene glycol into these toxic byproducts. He receives a dose of 15 milligrams per kilogram of body weight, followed by smaller doses every few hours. He's also started on haemodialysis, a procedure that removes toxins directly from the bloodstream, and given vitamins thiamine and pyridoxine, which help redirect metabolism down safer pathways. After 8 hours of dialysis, his condition begins to improve. He becomes more alert, his acid levels decrease, and his osmolar gap begins to normalize. On the third day, the breathing tube is removed. By day 6, his ethylene glycol levels have dropped below the threshold of toxicity, down from a staggering initial level of 13,000 milligrams per deciliter, almost 12 times higher than any previously recorded case. He confides in the medical team. He had attempted to take his life by drinking 250 milliliters of antifreeze. He says his alcohol addiction felt impossible to escape. Psychiatry is consulted, and after 6 days in hospital, he is discharged home with a referral to an addiction support clinic. But 1 month later, he is found again, this time in a motel room, with a note that reads, "Please do not resuscitate." By the time emergency services arrive, he is in cardiac arrest. They perform CPR, deliver shocks to his chest, and insert a breathing tube. On arrival to the hospital, he is deeply unconscious once again, with a Glasgow coma scale of 3. His blood pressure is dangerously low at 85/43, and his body is hypothermic at just 30.5 degrees. Though his breathing rate is elevated at 24 per minute, there are signs of neurological disturbance. His head jerks rhythmically, and his eyes twitch in response to sound. Initial blood work shows severe acidemia. His pH is just 7.10, and lactic acid levels are extremely high at 15. His osmolar gap is again elevated, now at 125. There is no ethanol in his system this time. His kidneys are not producing urine, and the microscopic examination of his urine shows needle-like crystals, often a hallmark of ethylene glycol toxicity. Considering these findings alongside his presentation, several differential diagnoses emerge. Methanol poisoning is one, as it can also cause high osmolol and anion gaps, but his screen is negative. Isopropyl alcohol and ethanol are also ruled out for the same reason. Ultimately, the presence of crystals in his urine and his clinical history point again to ethylene glycol poisoning. He is immediately given fomepizole, sodium bicarbonate to correct his acidosis, and intravenous fluids to support blood pressure. He is started on haemodialysis again, this time with a high-flow dialyzer. After 14 hours, there is no urine output. His condition remains critical. Continuous dialysis is started. Despite these efforts, he shows no signs of improvement. His ethylene glycol level on admission was 385 milligrams per deciliter. Glycolic acid, the toxic byproduct, was extremely elevated as well. But even though these levels are brought down with dialysis, his organs have already sustained too much damage. His brain does not recover, and he passes away on the 4th day of hospitalization. This case tells a profound story, one of timing, metabolism, and missed chances. Ethylene glycol is rapidly absorbed by the body, and within 1 to 2 hours, peak blood levels are reached. Without treatment, it is cleared by the kidneys with a half-life of about 6 hours. But once metabolized, its byproducts begin damaging tissues. The damage begins in the brain and gut, then moves to the lungs and heart, and finally, the kidneys fail. These stages often overlap. Interestingly, when ethanol is co-ingested, as it was in the first case, it acts as a competitive inhibitor of alcohol dehydrogenase. This slows the production of toxic metabolites and may help explain why the patient survived the first poisoning despite a massive dose. But during the second admission, there was no ethanol present, and the delay in seeking help may have been longer. Monitoring patients with suspected ethylene glycol poisoning involves repeated assessments of acid levels, kidney function, and blood osmolality. Since the actual ethylene glycol test is often only available at specialty labs with delayed turnaround, doctors must act based on clinical suspicion. The presence of a high osmolar gap, particularly in combination with a high anion gap, is a strong indicator. Treatments include fomepizole to block the toxic conversion process, haemodialysis to physically remove the substance from the blood, and sodium bicarbonate to neutralize the acid. Cofactors like thiamine and pyridoxine help support safer metabolic pathways. Globally, ethylene glycol poisoning is rare but deadly. In the United States alone, there are dozens of deaths reported each year. Most cases are accidental or linked to alcohol misuse. Between 2006 and 2013, around 45,000 exposures were reported to poison control centers, with over 150 resulting in death. This case gives us several important lessons. First, time is everything. Even massive doses can be survived with early treatment, while delays, even with smaller doses, can prove fatal. Second, the presence of ethanol may temporarily slow toxic progression, but it is not a substitute for medical care. Third, doctors must often act before laboratory confirmation is available, using bedside clues such as the osmolar gap and clinical signs like coma or acidosis. Fourth, managing ethylene glycol poisoning is complex but possible with the right tools, antidotes, dialysis, and supportive care. And finally, the underlying reasons for poisoning, whether accidental or intentional, must not be overlooked. Addiction is a disease, and without support, patients may find themselves in crisis again. Introducing third and final case of this evening, a 55-year-old man and his 54-year-old wife, living together in a modest home in southern England. It's mid-February, and the countryside outside is grey and still. Inside their home, a warm gas fire glows in the lounge. But something is wrong. Neighbours, concerned after not seeing the couple for a day, call the police for a welfare check. Officers enter to find both the man and woman confused, agitated, and collapsed on the floor in their pajamas. Broken glass and disturbed furniture suggest a frantic struggle. Vomit stains their bedding and clothes, while their dog appears healthy and alert. They are rushed to the hospital, where we pick up the case now. The woman is retching, incoherent, and swiping at objects that aren't there, a clear sign of visual hallucinations. Her pupils are fixed and dilated, meaning they don't react to light. She is hypertonic, with muscles unusually rigid, and hyperreflexic, meaning her reflexes are abnormally brisk. She has a fever of 38 degrees Celsius and neck stiffness, which raises concerns for brain infection, such as meningitis, inflammation of the membranes surrounding the brain. Her blood pressure is stable, and her pulse is at 100 beats per minute. Her husband is also confused and highly agitated. Like his wife, he's sweating profusely and febrile. He has a pulse of 110 and elevated blood pressure and vomit around his mouth. One side of his body shows an upgoing plantar reflex, sometimes known as Babinski's sign, where the toes of the foot flex upwards instead of downwards when the sole of the foot is stroked. This is an abnormal sign, often indicating central nervous system irritation. He too has neck stiffness. There's no history of mental illness, substance use, or recent travel. No medications are found in the home. There is no sign of gas leaks, and the couple had not been drinking alcohol. In the kitchen, canaries chirp in cages, a hobby of the couple, but all are healthy. The fire was on, but the patient's blood gases and carbon monoxide levels are normal. Considering these findings alongside their presentation, several differential diagnoses emerge. One possibility is encephalitis, a brain infection often caused by viruses, but both had normal cerebrospinal fluid, brain imaging, and chest x-rays, which ruled this out. Another consideration is psittacosis, a bacterial infection linked to pet birds, of which the couple has many. However, blood work and imaging again fail to support this. Botulism, a rare but life-threatening bacterial poisoning, was briefly considered, but the presence of hallucinations, fever, and dilated pupils made it unlikely. Attention turned to possible poisoning, perhaps with an anticholinergic agent. These substances block acetylcholine, a key chemical used by nerves to communicate. Tricyclic antidepressants, certain plants, and even some over-the-counter antihistamines can have anticholinergic effects, causing symptoms like confusion, dry mouth, vision changes, and hallucinations. Then a crucial clue emerged. Seeds were found in the vomit of the man. Their adult son brings in a jar from the home containing leftover fruit. On closer inspection, the team identifies black seeds. Samples are sent to the Royal Botanic Gardens at Kew. As this unfolds, both patients are sedated, intubated, and moved to intensive care. They receive supportive care, fluids, ventilation, and gastric lavage to flush out remaining toxins from the stomach. They are monitored for heart rhythm, muscle breakdown, and brain swelling. Blood tests show elevated white cells, a mild rise in liver enzymes, and a significant elevation in creatine kinase, an enzyme that leaks out of damaged muscle. However, kidney function remains normal. Myoglobin, a protein from injured muscle, is not detected in the urine. The woman begins improving by the next day, still foggy but more coherent. The man deteriorates slightly before improving, suggesting a delayed release of toxins further down the gut, a process known as delayed gastric emptying or gastroparesis, often seen in anticholinergic toxicity. By day 4, both are awake and much clearer. Vision remains blurry and they complain of abdominal bloating and dry mouth, but the confusion and restlessness have resolved. Finally, the mystery is solved. The woman recalls that back in August, 7 months earlier, they had gone for a walk through Berry Hill National Park. They had picked a mix of wild berries and frozen them for later use. On the night of their poisoning, they had made a pie using these fruits. The berries had looked like blackberries, but some were not. The pie contained both frozen blackberries and fruits from Atropa belladonna, commonly known as deadly nightshade. Atropa belladonna is a plant native to Britain. It grows in shaded woods and rough soil and produces small, shiny black berries. These berries contain atropine, a powerful tropane alkaloid that blocks acetylcholine receptors in the body. Atropine causes the nervous system to become overstimulated. In high doses, it leads to hallucinations, muscle rigidity, high heart rate, and confusion. Heat, such as cooking, does not destroy this toxin. Testing confirms high concentrations of atropine in the leftover pie and in both patients' urine. The levels in the man's and woman's urine were over 1,800 micrograms per liter, consistent with significant poisoning. Interestingly, serum levels, those found in the blood, were already low, highlighting how quickly the body clears atropine from the blood, even while symptoms remain. The man had received a dose of physostigmine, a drug that reverses anticholinergic poisoning by raising acetylcholine levels. But as seen in previous studies, this treatment didn't work. The symptoms persisted. Physostigmine is unreliable in severe atropine poisoning and may have side effects, so supportive care remains the best approach. By the 6th day, both patients have recovered. Their blood tests return to normal and they are discharged. Poisoning from deadly nightshade in adults is rare. What made this case especially unusual was the timing. Midwinter, months after the berries had been picked. Freezing the fruits preserved the toxin. It's also important to note that the couple couldn't remember the key events until several days later. Memory loss is common in anticholinergic poisoning. Historically, deadly nightshade has been both feared and misused. In ancient times, it was a poison of choice for assassins and a hallucinogen in folk rituals. Today, it grows innocently alongside paths and parks, but its berries remain a hidden danger. This case reminds us of a few key lessons. When two people fall ill together with no clear infection, always consider poisoning. Delayed symptoms may result from slowed digestion, especially in elderly patients or with certain toxins. Not all dangerous substances are destroyed by cooking. Supportive care is often the most effective treatment for toxic exposures. And finally, wild berries should never be eaten, unless you are absolutely certain of their identity. A single mistake can have serious consequences, even from something as simple as a fruit pie. Well, that wraps up our discussion on toxicology for tonight. From antifreeze to antidotes, these stories remind us just how delicate and remarkable the balance of the human body can be. Thank you for spending this time with me on Night Shift Scientist. If you enjoyed this episode, consider liking the video or subscribing to the channel. It helps others find these stories, and it lets me know you'd like more. I'll be back soon with another real case drawn from the pages of medical literature. Until then, rest easy, take care of yourself, and good night.